Good morning. Please welcome the Executive Director for Drug Prevention, Treatment, and Enforcement for the state of Indiana, Doug Huntsinger.
Well, good morning, and thank you all for joining us. Welcome to the Indiana Mental Health and Addiction Conference, the 2024 series. I know it's a little warm in the room. The generator went out this morning, and they have already fixed it, so the room will cool down to probably where it is too cold by the time we're done. Today, we're going to discuss the powers of peers, where we are fostering recovery through connection. At each of your tables, you'll see at least one individual who's wearing a pink name tag, and we've invited a select number of peers to represent the recovery community at today's event. Later this morning, we'll invite you to have a conversation with these peers to better understand their impact and how they are working to serve as a bridge to recovery for many individuals. Throughout the morning, we'll share the work being done by these peers in Indiana and showcase the positive results. We really hope to inspire many of you to embrace this approach and expand your workforce to include peers. For those of you who are already engaging in the recovery community through peers, we hope you will share best practices and learn ways to enhance and improve your recovery programs and support these invaluable individuals. So to kick things off, it is my pleasure to introduce the Director of the Division of Mental Health and Addiction, Jay Chaudhry. And as Jay makes his way to the stage, we want to show you a video we shared with more than 800 people last June. Asha Dis was named Peer Recovery Coach of the Year at our inaugural conference. Today, her organization is celebrating 5 years of serving Hoosiers in Northeast Indiana, and she joins us here this morning.
Project Me is a peer support and harm reduction organization here in Fort Wayne. What we do is we offer peer support services to people from active chaotic use all the way through to long-term recovery. And so we do things like distribute Narcan in a pretty widespread way. We also distribute safe use kits and other things like fentanyl test strips and xylazine test strips.
She's drawing from personal experience, and she is out there every day, connecting with people, meeting them where they are, letting them know they're not alone, letting them know they're valuable and they have worth, and their life is worth saving.
I'm a person that's in long-term recovery. I've been in recovery for about 14 and a half years right now. But it was still really hard for me in recovery to hear people tell me what I was going to be able to do and what I wasn't going to be able to do because of my felonies or because of my drug history, and none of it was true. At some point, I felt like I have to be able to tell other people this because there are so many people just like me who have experienced trauma, who have been to prison, who are addicted to drugs, who dealt with mental health struggles, who will just count themselves out because people tell them they can't. And I know that to not be true.
I was going through the probably worst time of my life. I, lost everything. She's always pointing out, like when I'm being negative or I'm doing negative self-talk, she's like, things like that, So she really has, man. She's put a light in my life that it's hard to put into words, to be honest with you.
He's just wholly thriving. He hangs out with his sons every weekend. He has a healthy relationship with a lady, which is something he would have told you wasn't possible for him. He has a great job now. And all I did as a coach was believe in him, listen to him, and let him know that the things that he expressed that he wanted in his life were possible. And that was so powerful for him, just to have somebody he could talk to, that he felt safe with, that would hold him accountable.
I have complete trust in Asha, and if you knew me as an individual, that's hard to gain.
Doesn't matter who you are or where you've been or what you've done, Asha's just gonna hug you and love you and tell you you're amazing and teach you there's nothing that you can't do.
I feel like this is exactly what I was put on this earth to do. People talk about alignment in life, and I just very much believe that what you put out in this world is what you get back. And so I try to put out good, and my good is loving people that are just like me.
All right, thank you so much, Asha. It's really an honor at DMHA to support folks like you out in the community, actually doing the work, and really that's what we get up for every single day, is to figure out ways we can support you all more. So obviously, I think a lot about what our big job at DMHA is, right? And it's keeps me up at night sometimes, and trying to simplify a really, really complicated thing is something I try to do. It's not always easy. But when we think about what we do, okay, we really have two primary things we can do to further our mission of improving mental health and addiction for Hoosiers, right? We can increase the capacity of the treatment system, right? And we can lower demand, or work to lower demand for that treatment system. And so we do this a bunch of different ways. I think on the demand side, I think you all know that's much more about life and about housing and flourishing and thriving and connection. And some of our prevention work kind of flows right into there. On the increased capacity side, we're doing pursuing kind of three primary strategies, right? We are building infrastructure with 988, with CCBHC, with our recovery network, because we know ultimately if we want this work to continue, not only for the next couple of years, but 5-10 years in the future, we have to have an infrastructure that supports it. And so we're making progress there. We're working on it. We're working on workforce, right? Because ultimately we know without people to do the work, nothing will actually get done. And that's sort of our single biggest limiting principle, is we need people to do the work, or we're not going to get anywhere. We're not going to have the capacity we need in our treatment system. And then we're working to enhance quality, because quality increases capacity by making sure that whatever interventions we do deliver are done in kind of the most evidence-based and high-quality way possible. So think about these 5 things. Okay, so increase capacity, reduce demand, build infrastructure, build a workforce, enhance quality. There's exactly one intervention that checks all 5 of those boxes. Only one of all of the ones we have. And that's utilizing peers. So that's why we're here today, because it's the most important thing we do kind of across the board, because it checks all those boxes. It helps us advance every single one of our goals forward. By utilizing the voices of folks with lived experience in the system. So that's why we chose the power of peers as a theme of our first summit. And one thing I really love, which I've observed lately, and it's been, I think, a really cool thing to see, is that the conversation is moving away from sort of recovery from things, right? And moving towards the things that you need to live life in recovery: connection, flourishing, stability, purpose, all of those things that everybody needs to maintain the life that we all want. And so I'm really encouraged by this direction of sort of a movement towards what I call like a positive recovery. And so that's the things I'll be thinking about as we go through our day today. We've got a great day planned for you all. And so it starts with Nikki Howenstein, who is the director of recovery at the Division of Mental Health and Addiction. So thank you for coming, and we look forward to hearing from you the rest of the day. Thanks.
Good morning. It's so great to see so many faces that are familiar and friendly faces here this morning. So I get the opportunity to talk a little bit about peers this morning and lived experience and how that really is how we're changing the dynamic of the behavioral health system. I will ask for some grace. I am fighting off of a cold, so I may be taking some sips of water and taking a little bit of break with my voice. So today I'm going to talk a little bit about the history of peers, how we got to where we are today, what we're doing within DMHA in the state with our peers currently, and kind of where we hope to go in the future. So my goals are that you learn something today, of course, and then also that at the end that we have a little challenge that you can take back and really go back into your organizations to look at the practices that you're doing and hopefully look at incorporating peers into the work that you're already doing or expanding on your peer work if you've already started with that. So why lived experience? This is something that seems so simple. We all have lived experience in multiple things, but the lived experience that we talk about with our peers really talks about, dives into life events that are just so either traumatic or life-altering that it kind of changes a person and who we are and how we view different things within our lives and the lives of others. And so that lived experience really is not something that can be, gained with your degree, something you learn from media, watching different TikToks, right? We have a lot of ways that we gain information, but lived experience really is something that we walk through and come out on the other side of, and through that walking through really learn valuable lessons that can't be learned otherwise. And so I will give you a little bit of history for me and what led me into this position at DMHA. I do have I have 3 children who I adore. And so we had a great family, raised those kids, and we thought we were doing everything we needed to do as parents. And when my daughter was 20 years old, found out that she was struggling with some addiction issues. We had seen the signs of she had lost weight, not always coming to family events. If she did come, she would show up late. Just changes in her behavior that we knew were not right for her. But at 20 years old, she was kind of off living, her own life, taking some college courses, living with her girlfriends. And so we weren't really sure what was going on until she finally came to us and said, look, I've got a problem. And she had been using methamphetamines. 15 years ago, this was a very bleak outcome. When we sought advice, help from folks, we were told that this is really not something that people overcome, that she would likely die, and that we kind of needed to start planning for this to occur. There was very little hope. Fortunately, we did find a treatment center that she went to and completed. Went on to college and gave me my grandbabies and is living a wonderful life now and really giving back into the peer world herself with her journey. And so just a wonderful success story. My son, who is 4 years younger than my daughter, and looks up to her and has looked up to her his whole life. Kind of went down the same path, and his journey has been a lot more difficult. He moved to Florida, in and out of incarceration. I think his drug of choice was heroin. He was an IV drug user, but he would tell you that it didn't really matter what the drug was, right? He just was escaping something in his life. The trauma, I think, for him snowballed with his homelessness, being in and out of jails, in and out of treatment centers that just really, I think he wanted to find his answers, but he was unable to. He did find recovery in his last treatment that he completed in October of 22. Yes, October of 22. And maintained what would be to us a life of recovery for several months. But unfortunately, the trauma that he experienced, his solution had been the drugs. That's what his treatment was. That's what he was using to cope. And when that was taken away from him, unfortunately, we lost him, as many of you know. So I am in this deep. This is a passion of mine for myself, for the families that are walking in the same shoes that I am, and for the individuals who are struggling, because I have walked beside this journey for such a long time. So lived experience to me is everything, and it's how I know the gaps in the system. I've been able to recognize them because of the journey I walked, but also measure the successes that we have had, which are tremendous in the last 15 years since I was given very little hope for the future of my children. All right, so what is a peer? Well, we have a lot of peers in the room today. I'm a peer. I consider my lived experience both as a family member and my own personal struggles with mental health. I've clearly struggled a lot with my own mental wellness through the things that I have had to be a part of. And so that lived experience is vital to peer work, but also we're willing to put ourselves out there and talk about it. We put the drive to help others behind our work. And so that really is what makes a peer. We like to offer what we've learned as a roadmap to others to help them on the same journey. We have recently come out with a new curriculum at DMHA. We'll talk about that a little bit later. But with that new curriculum, our CPSP, we've come up with a new definition for what lived experience, what peer work is, and really it is just combining that lived experience to inspire hope with others, along with professional training and the certification that comes along with that. So we're going to go in a little bit to the history of how did we get here? How did we get to where we are today with peers? And so this is going to go way back into the 70s, where a lot of the pro-rights movements occurred. Hopefully a lot of you are familiar with just a lot of the things that were occurring in the 70s. One of the other things that occurred was a lot of our state hospitals shut down, and folks that had been struggling with mental wellness challenges were, moved back into the communities, and often met with stigma and shame from the community. They were not always embraced, and often felt like outsiders. This really led these individuals to kind of start finding each other and leaning on one another, because they had felt very failed by the systems who had put them out into the community. And so this bonding together, this connection that they were finding based on their own lived experience, really drew them together. In the 1980s, we started seeing some self-help groups popping up. They were getting, these peers were starting to form larger groups to help support one another. And this really led into advocacy work, and these individuals looking at the brokenness in the systems and finding the best treatments that were out there, so that they could tell their friends and the people that they knew, like, these are the programs that are working, these are the programs that are not. So they were advocating for themselves outside of the systems that they had felt had failed them. Fast forward quite a bit into August of 2010. Many of these individuals nationally came together with SAMHSA, the leadership at SAMHSA, to come together for a unified definition of recovery that you'll see on the slide. This really was a big change, a big shift change for many reasons. One thing was that it brought substance use and mental health recovery under one definition, so it united the recovery movement. These before had been, separate, which really complicated the way that insurance was billed and just our system overall. And the new definition allowed for recovery opportunities for families, for peers, for funders, and just united the movement overall. So in Indiana, we'll briefly come back home here for a second. Key Consumer, which started in 1984, was started locally by a group of individuals with lived experience with mental health, mental health conditions. They became a not-for-profit in 1988, and in 1992 came under a 501c3 with an all lived experience board of directors. And today, Sarah Gunther, who is in the room, and you'll get to meet earlier, she's the executive director, and so Key is still going strong and a partner that we have at DMHA today. The Indiana Addiction Issues Coalition started in 1999. And so this was a group that was more in the substance use space. And so they really became our first RCO in the state that was advocacy and education around for peers around substance use. In 2015, many of you know, we made national news for the HIV outbreak down in Austin, Indiana. And due to that crisis, the community came together to form what would look very similar to what our hubs would look like today for that community, to ensure that folks had access to HIV testing, work opportunities, transportation to and from the hub, and referrals for treatment, referrals for recovery, for work, whatever they needed at that time to help them get to a place of wellness. And the IAIC was able to send down peers and mobilize them to help in those efforts. The mobilization of that one-stop shop in Austin, as it was called, really laid the groundwork for what we would later face when COVID hit our state in 2020. We had a very short amount of time to stand up 22 recovery hubs through a partnership with DMHA and the Indiana Recovery Network to ensure that every person in the state of Indiana had access to peer support for the first time ever. So where are we now? We are working very hard to professionalize peers within the state of Indiana. We did this through the launch of our CPSP, our Certified Peer Support Professional, in January of this year. We got really lucky in that when we started this project in January of last year, we were in the early stages when SAMHSA rolled out their national standards for peer support. And so we were able to study them and align our curriculum with the national standards. A lot of states are looking at that now and trying to recreate, so it was a lucky thing that we were creating our curriculum at the same time. And so we have aligned our curriculum with the national standards. All of our curriculum was designed by subject matter experts in the state of Indiana, so our peers, our folks with lived experience. And as Jay mentioned earlier, we are really striving to work around DMHA's priorities, which is building our infrastructure. So our hubs, growing our workforce through training our peers, enhancing the quality of those peers through a professionalized certification and a proctored exam to ensure that we are putting out individuals that know what they're talking about and are ready to work and be there for those connections that we need within that peer space. We have developed our curriculum as a no wrong door approach, so it is a holistic curriculum that incorporates mental health, substance use, trauma, family peers, amongst a lot of other things. But those are the things that we really focus on. We want our peers to be ready to meet anyone that needs a peer, meet those needs initially, and not pass them along until they're ready to be handoff if they want someone with that same lived experience that they have. But we always want to be able to be there and connect with someone and be prepared to offer our listening ear and support them as they come. We've also removed barriers that had existed in our curriculum, one being recovery time, and the other being any cost fees associated with becoming a peer. We are covering the cost of the certification to ensure that we get folks into that space that are passionate about the work. We also have full-time trainers now that train at Ivy Tech, our Ivy Techs across the state. Our trainers all have lived experience as well. And we are proctoring our exams also at Ivy Techs across the state. We also do have a crisis certification that we've rolled out, crisis peer supervisor certification that we've rolled out, and those are also trained by individuals with lived experience. We recognize that is a priority for us. So here's a little bit of information about our hubs and where we are currently. This was put out by Next Level Recovery. So this is data that was gathered in December of 23. So at the time of this report, we had 186,000 services that had been given to participants across the state of Indiana. I would venture to say I think we're probably close to 200,000 by now, being that it's May. But as you can see, our hubs offer, that individual peer support, group peer support, referrals for things such as housing, employment, community connections, whether that be like the local Y or other things that are going on for, families, just to give them something to do to help sustain their recovery. And obviously transportation, which we all know is a big barrier for a lot of folks across the state. So where are we now as far as our infrastructure? So we've talked about the hubs. We do have 20 hubs currently. We have combined some of our counties into 20 hubs. We still are offering all the services across the state for individuals, and our hubs really are the backbone of our infrastructure. We also are at 20 recovery cafes. Recovery cafes are community-oriented places for folks to go and just be with others in recovery and find support. And we are standing up many other RCOs across the state, recovery community organizations. We are, again, trying to elevate the value of peers within our recovery ecosystem, inspiring hope through transparency in our recovery. I hope you've been watching the slide. We talked a little bit about our Summer of Recovery tour that we do. This is our third year doing that, and so we have identified 5 communities in the state where we come and just set up music, and it's family friendly, and we celebrate recovery. And we hope to not only celebrate it for ourselves, but to instill that hope within the community for those that may not always look at people that are struggling as somebody that they can help, and that there is hope, and that we can reduce the stigma and the shame that often goes along with individuals who are struggling. We also are ensuring standards for RCO certification. We recently had a House bill that was passed that goes into effect July 1 of this year that amends the Indiana Code, that allows DMHA to provide standards for certification, which codifies the need for the importance of recovery community organizations in the state. So a little bit more about RCO certification. RCOs are just grassroots organizations that are community driven, and they provide activities, support to members in that community that are in recovery or seeking recovery. Our RCOs are 501c3s, and they focus on 3 core values: recovery vision, authenticity of voice, so that lived experience is at the head of the decisions that are being made, and accountability to the recovery community to make sure that we are using best practices and evidence-based practices within those organizations. We follow the national standards set by Faces and Voices of Recovery in our RCO certification, and there is more available on the website with the Indiana Recovery Network if you're interested in that. This is my team. We are all here today, so if you would like to say hi to my other team members, Danica and Andrew, please do so. We are a growing team. As you can see, we are fairly new in our roles, but we are all very dedicated to the work that we do. DMHA has had lived experience voice within the agency for over 2 decades. But for the first time ever, we've grown this into first 2 positions and now 3 when we brought Andrew, who you will also meet later today, onto our team in January of this year to take over our peer program. We all do have lived experience, which is, again, so important to the work that we do. So what's next for the recovery team? Well, we are updating our website. That should be live at this point. We've changed our name from the Office of Consumer and Family Affairs to the recovery team, which is really what we focus our work on. It seemed kind of an easy jump. But we will be having our CEUs on our website for peers so that they can get good training that will count towards the CEUs that they will need to earn to keep their certification. We are focusing on a peer supervision certification. That is one of the things that we are working very hard at right now. We do believe that peers need to be supervised by individuals with lived experience if at all possible. This too follows SAMHSA's national standards that peer supervisors have direct experience as a peer worker, that they have knowledge of the peer worker's role, and that they understand the principles and philosophy of recovery and resiliency, and that peer supervisors be familiar with the code of ethics that our peers are guided by and that really drives the work. So what's next for the infrastructure? I mentioned earlier that the recovery hubs, regional recovery hubs, really are the backbone of peer work and what we do with recovery, and that will remain the same. Again, it is the way that all individuals in the state can have access to peer support is through our hubs. We are building our recovery community organizations through certification that we talked about a little bit ago. And we're also looking at a standard for recovery community centers. Recovery community centers are just peer-oriented centers that serve the local community through resources. And we're looking at the criteria for those spaces now. So look for more to come on this. Recovery community centers are just places that may not fit into the criteria for a recovery community organization, the RCO, but also are not a hub, but still are offering valuable resources to the community and a place that people need to go to in order to have the support that they need in their recovery. So what's next for support? This was kind of my call to action I talked about at the beginning. There's a mind shift, I think, that can take place when we're talking about supporting each other and people that are seeking recovery. And really, it's a harm reduction approach to what we have been so familiar with, mandated reporting. So mandated supporting really means, rather than calling someone that may turn out to be punitive for a family or an individual, what resources are available in our community? What resources are available within our organization that we can link to make sure that safety is secured without having the damage that can often come and the trauma that can come by taking a more punitive approach? So the challenge is for me that I'd like to give today is for you to go back and maybe look at some of the policies that you have. What kind of things within your organization can you look at with a different lens of mandated supporting versus the mandating reporting that we often have fallen into historically? This slide comes from a project that we started, a research project that we started in February of 22. The project was for a return on investment within our recovery infrastructure. And these are direct quotes that came out of that 94-page research report, which will be also coming available in the future. But it really lends to what is going on in our recovery organizations across the state, that people feel loved and accepted there, that they feel that the things that they need are accessible, which they've not felt before. And so there were so many quotes throughout this report, but I pulled a few just to kind of help you see some of the feedback that we had gotten from that research report. So now I am going to kick this back to your tables to have a little conversation. There are some notes there, or some questions, I'm sorry, if you'd like to look at those prompts. But each of you should have a peer at your table. And so this is just a time for you to ask them questions, hopefully learn something, learn from one another. And so I think there's 10 minutes for this next part.
So up next, we have assembled a panel of peers to share their work and to discuss the importance of connection in an individual's recovery journey. By employing peers, we're breaking down barriers and creating life-changing relationships. To moderate this session, I am excited to introduce to you Andrew Fuqua, whose story is nothing short of extraordinary. As he and the panelists make their way to the stage, please join me in watching Andrew's story.
Well, I'm in recovery from quite a few things.
Substance use disorder, panic disorder,
heroin and meth addiction.
The methamphetamine abuse.
My name's Andrew Fuqua. I'm 35 years old. Live on the south side of Indianapolis. I have two beautiful little girls. One's name's Alize, one's name's Aaliyah. About to be 12 and 13 next month. I am the first peer program manager with DMHA. I think peers are the most important part when it comes to a person's recovery. At least in my story, when I was going through my madness, I entered different stays of different facilities and treatment centers and things like that. And I never sat down with somebody that actually sat across from me that I could believe ever been through anything that I had been through. I had a guy come up to me, and I really enjoyed who he was as a person. I could tell from his stories and just the way he held himself that he had been through a lot of similar things that I had been through, but I really appreciated the way he handled situations now. He actually kind of walked me through the rest of the phase of that treatment, and still to this day I keep in contact with him. So I really feel that peers are the bridge, the bridge to treatment, because if he wasn't there, I probably would have left and I wouldn't have received the other services. The other services are essential to sustain recovery, but to get to those services, I think you need somebody you can connect with and just have an everyday conversation with and feel like you really relate to. It's nothing short of a blessing for me to be here today, honestly. Both physically, and spiritually, I shouldn't be alive today, let alone, be able to work here with the state. So it's a huge blessing. Managing the certified peer support professional and credential and the trainings that go around the state allow me to connect each one of these peers with individuals that were just like myself at the very beginning that needed that peer to to kind of latch onto and hold on to help them through their journey and to show them a different path of life and just kind of bring them up out of the darkness and literally show them that there is daylight, you know, and there is another way to go. Thank you. I want to thank you all for being here today. I'm honored to be here to highlight the significant contributions of certified peer support professionals and the value they bring to the workforce. Joining me this morning is Nicole Barrett, a certified peer support professional trainer. And then we have Sarah Gunther. She's the executive director of Key Consumer. And then we have Alicia Wells, founder of Wells of Inspiration. Just a short bio for each one of them. Nicole Barrett is the trainer for the Indiana Division of Mental Health and Addiction Certified Peer Support Professional Curriculum. Drawing from her personal experience with substance use, mental health, incarceration, and sex trafficking, Nicole has experience as a certified peer support professional in harm reduction and street outreach, empowering individuals to embrace a holistic approach and support all pathways to recovery. Next, we have Sarah Gunther. Sarah Gunther is the executive director for Key Consumer, a consumer-run organization that provides empowerment and support through its peer services and mental health warm line. Sarah is a person in recovery with mental health challenge and substance use disorder. Sarah started her peer support career at Key Consumer in 2008 as a part-time warm line operator and worked her way up to executive director in 2019. And last we have Alicia Wells. Alicia Wells Alicia Wells is the creator of the Wells of Inspiration, LLC. As a business consultant, Alicia helps organizations achieve a sustainable presence and recovery culture through community collaboration, events, fundraising, brand awareness, and access to quality vetted resources. Her dedication to improving the lives of those affected by substance use disorder is evident in her compassion and an innovative approach to her work. All right. Next, we'll just all go through these questions and we'll see some answers and have some good conversation here. So, each of you bring a wealth of diverse experiences to the table, and I'd like to give each of you an opportunity to share what motivates you to become a peer and how your personal experience drives you to do the work you do. We'll start with Nicole.
What motivates me to be a peer is the fact that this wasn't accessible years ago when I started my recovery, and this sheds a whole new light onto what is possible for people in recovery. When you have somebody standing next to you that will support you and guide you and let you make decisions is so empowering. And it shows that the love that people have for one another, there's nothing compared to it.
Next. We can go, Alicia, what about you?
What started my journey to be a peer was being incarcerated. I came from a great family, great home. So when I was navigating my journey of substance abuse, there wasn't a lot of knowledge like there is today. And it was being incarcerated, literally sitting on a bench at the IWP, talking to people who were just like me, going through the exact same things. I was never so alone in my mind thinking I was the only one that this had happened to, when in fact there's hundreds of me's. And I knew in that moment that I had to do something. I was encouraged to give back. And so that's what helped me begin my journey.
Absolutely. Sorry, Nicole, thank you too. And thank you for your response. I can relate a lot to that. And I think that's something that we all share, right? Kind of that feeling of loneliness and just being lost and then running into somebody and finding daylight again and being able to, make it through. What about you, Sarah?
Well, I started as a part-time warm line operator in 2008. I was kind of in and out of the hospital for bipolar disorder on Social Security disability, but I wanted to help people. I didn't know how I could help people because I wasn't doing, real great myself, but I went through Voc Rehab. I said, I want to find a way to help people, and they said, well, Key Consumer Organization is looking for a part-time warm line operator. Are you interested? You'll be using your lived experience to help people. And I was just like, yes, please. And so I went and I had an interview with the executive director at the time. She was a person with lived experience. She had been on disability and moved not just to full-time work, but full-time as an executive director of a mental health nonprofit. And so that was so inspiring to see somebody who had lived experience, pretty severe lived experience, and not just recover, but help others in their recovery, advocate for others. It was hugely inspiring, and I went from working part-time on the warm line to going off of disability, working full-time as office manager, and then I had the opportunity in 2019 to take over as executive director and run the programs in the warm line and support the other individuals and really use my lived experience with mental health issues and substance use to help others.
Yes, I love that. All right, Alicia, what distinguishes the role of the peer from that of a traditional healthcare provider or therapist, and why is this distinction important?
Well, great conversation was happening at our table, and I hope it was happening at your table too. And one of the main distinguishing factors is that a peer comes with that lived experience. Talking to somebody who has walked the walk and been where you've been, or has had some of the same struggles, thoughts, being around that and supporting the person next to you allows an opportunity for growth for the person and the peer, but also for the treatment team. I think it completes that treatment team. It completes the piece where, as a peer, your perspective, your thoughts on a situation, it gives a more, I like to say, valuable approach, not so much from the clinician standpoint that they know what they need to do, but the peer has walked the walk. So I think that is really what distinguishes the difference between the peer and the clinician, and it just completes that team with the experience.
Yeah, that's a great answer. Right, next, so this one's for Alicia and Nicole. Alicia, what distinguishes the role of a peer from that, sorry about that.
That's
What
all
about
right.
you? What about you, Nicole? What's yours for that?
Yeah.
My apologies.
Yeah, okay. Like Alicia was saying, that's the tie that binds, right? Is that we have lived experience, and when we come into a room with an individual, we don't really have to say too much to them because there's certain keywords and lingo that happens that I don't have to tell my whole story to this person to gain trust or gain a bond. Just them simply knowing that I've come from the same place that they've come from, and I'm the bringer of hope, right? I'm the cheerleader, and that I have their back makes people open up to you and have a layer of trust that they may not have had with anybody else in their entire life. And then you just do things with them that just builds on that relationship. And there's just nothing whatsoever compares to somebody coming in and supporting you for no reason, except for they want your success.
Absolutely.
I want to add to that real quick too, Nicole, to the point when we're talking about the peer, when you come in and you say that trust and that credibility part, the person is already at their lowest, and when you're sitting there, there's no judgment from your peer. Mm-hmm. Sitting up here right now, not being able to get into this chair could have been embarrassing, but Half of y'all know crazier stories about me in this room, right? So,
I read the same question twice.
It's all right, Andrew, I got you. So what makes being a peer is that comfort piece, too. You can automatically just take a sigh of relief because you know that you're not being judged. And I know that sometimes walking into a therapist's office, I don't want to tell them everything. But I know that there's some people in this room that I would tell anything to. And I think that also is a key factor.
Yeah. Something about the presence, right? You
Yeah,
just feel it in
definitely.
their presence. Awesome. Those are great answers. All right. Sarah, through your work with Key Consumer, how have you used your organization to bridge the gap between patients and providers and advocate for the needs of individuals you serve?
Well, one of the big ways that we advocate is through our connections with like the state and CMHCs and organizations, because we show that it's possible to recover. We show that through our lived experience, through the way we help people, we have that empathy, we have that hope because we've been able to do it, and we just show everyone that it is possible. And not only can you live and thrive, but you can help others through the peer experience, and that gives you a purpose that makes it easier to get up in the morning when you're depressed, or makes it easier to take your meds if you're having issues, or makes it easier to go to AA if you really are tired and you don't want to. But it gives you that sense of purpose, and it gives you that sense of community. You can reach out to other peers. I'd have helped you on the chair. I did my best. Sorry about that.
You really did. Thank you so much. I don't know which one's going to help me off because it seems like a long way down, but we'll see.
Between the four of us, we'll get you off the chair.
The power of peers right here, ladies and gentlemen.
That's funny.
But yeah, I've been able to use my lived experience to give hope to everyone, especially the peers. And if your therapist doesn't think you're ever going to get better, why would you? But if your therapist sees someone who's a peer, or the state sees someone who's a peer who's just able to just thrive and help other people, they're going to have hope for you. If you see peers and you see them, you're going to have hope too.
Yeah, absolutely. Thank you. That's a great answer. Alicia, having founded your own organization dedicated to your purpose, I'll pose the same question to you. How have you helped bridge the gap and advocate for needs of individuals?
I think one of the ways that I'm able personally to help bridge the gap is I'm not afraid to say hard things. Yeah. I'm also not afraid to admit when I'm wrong. And I think over the last 6 months, what made me step outside of the box was I didn't take care of myself in my own recovery being a peer. Yeah. I put everybody and everything, and I didn't like who I became through that process. Yeah. And I mentioned to many of you, today felt like the first day of school. Yeah. And so being able to say when things aren't working, when things aren't perfect. And I think that's what helps me bridge the gap, is that I'm able to stand with people and say, it's all right, let's try again. And I think Wells of Inspiration has this opportunity to advocate for those coming out of incarceration, because I want to bring people along with me. My peers are the best people I've ever met. And I can't wait to see more and more people in professional roles doing amazing things and putting their old life behind them. And it's exciting to be able to advocate for other people, because I don't want another mother to go through what I went through.
Absolutely. Yes, thank you so much.
Can I say something real quick?
Yes.
I do want to point out that a lot of peers aren't afraid to say the hard thing. Yeah. Because we know that it helps. The hard thing, somebody might not want to hear it, but even in a meeting, if you want more of the same, well, then why do you have a peer? Because their lived experience is going to tell you the hard thing. Mm-hmm. And that, sometimes we need to hear hard things. Maybe what we're doing isn't working for everyone, and maybe we need to know that, and maybe a peer will tell you that, and that's going to hurt. But you need to know that anyway. So, peers will say the hard thing.
Yeah. And it touches on what we talked about a second ago with, how the person interprets it, right? As a peer, when a peer would say that and send that message to somebody, they might really at least in my situation, grab onto it and take hold of it, whereas somebody else, a doctor, clinician maybe, you're more hesitant to believe it and kind of want to argue the facts. So absolutely. And it leads to the next question, right? So you mentioned different challenges. What challenges do we encounter in your work as a peer, and how do you address them? We'll start with Nicole.
So training the people to become peers is a vital role. Like, knowledge is power. And when people go into these roles just, willy-nilly, and you're brand new and you don't have any training or knowledge on the subject, you just have your life experience. That's something that's irreplaceable, right? But when you have life experience and knowledge put together, it opens up a door for people to have care, right? So that everybody in the system is actually getting cared for by another person, and they're caring for themselves, right? Because we know how to go into this situation so that we don't burn out, and so that we're not over-giving, and so that, they learn coping mechanisms and skills that they have never learned before. It's super, super important for people to have the knowledge, and I love training the peers of Indiana, because it has opened my eyes to how much care and what kind of movement is happening right now, that nobody else has to die, for something that is preventable. And I'm just glad to be here.
Thank you. Sarah, what about you? What kind of challenges have you faced, and how do you overcome them?
Challenges, self-care, it can be hard because you want to overgive, because you don't want to see anybody go through what you went through. But you have to take care of yourself in your recovery, not just because so you can take care of other people, but because you actually deserve it, and you have to believe or have someone around you that believes that you deserve it until you believe it yourself. Just like that's the peer's job for our consumers. Okay. Find somebody, if you don't believe that you deserve to take care of yourself, find somebody who believes that about you and listen to them, and get peer support yourself. I think one of the things we were talking about at the table is sometimes peers, they've never had a professional job or something. And for me, learning how to mess up was crucial. Learning that you can mess up and not let it just completely snowball, or you don't have to give up just because you mess up. You have to apologize, you have to make amends, you have to, you can learn from this. A stumble may prevent a fall. There's all this stuff, but as you have peers, if you see, they make a mistake, they accidentally do something wrong and they fall apart, we all make mistakes. Perfection is just absolutely never gonna happen. So, I think peers learning for themselves that they have a spot at the table and learning how to mess up and keep going can be a challenge.
Yeah, absolutely. What about you?
I would also say self-care, but I'll touch on something different, and it'll piggyback off what you said. Believing that you're worth it. Mm-hmm. Believing that your goals and your dreams to have better, to be better, are okay. Because many times I feel like I hit a point and that's all I was worth. That was good enough. I made it out of that, so I'm here and that's good. And then I wanted more goals. A lot of people like to call me bougie to be funny. But I am, and that's okay. Right. I like to say I get it from my mom, right? But I work hard, and I want to have nice things, and I want to keep attaining these goals and these dreams, and I'm worth that. And it took the last 6 months of some really hard work to realize that. And so I think as a challenge for peers, realizing that it's okay to step up in the game. It's okay to keep going. It's okay to have bigger dreams.
Absolutely.
Yes. I love that. Those are great answers. All right, Sarah, you've previously emphasized the importance of increasing the number of mental health peers. Could you talk about this need for more individuals with lived mental health experience in the peer workforce?
Yeah. because we know that, with substance use peers, we know that lived experience is crucial, but it's also with mental health. Somebody has to be able to talk about this. You have to have a role model who says, I've done it. I know you can do it. I know how hard it is. I know, but you are worth the work you're putting into. And it isn't just that it's hard work so that you can maintain the status quo. It's hopefully hard work so that you can thrive. Yeah. Hopefully it's hard work that you have more, and it's in the direction you want, not the direction somebody else wants. And because I don't think, just like compliance is going to be enough to keep people doing the hard work. Mm-hmm. I'm not going to get up when every piece of my body wants to stay in bed just because my therapist says it's going to work. I mean, I have to have something to get up for. I have to have a life that I'm going to move toward. And I don't want anyone to settle for, this is as good as I can get. And I think peers will help us all realize that people with mental health challenges can still attain things, thrive, live the life that makes sense for them. They may not, become ultra successful, but maybe it's because they don't want that. Maybe they are not interested in that, because you have to sacrifice for every good thing. There is sacrifice, and maybe they're like, okay, this is good enough. That's good enough for you. If you don't want to give more, that's fine. That was something that was hard for me, was realizing that not everything is going to be worth my time and attention, and so I only have so much time and attention, so I have to pick and choose, what I'm going to do, and I really feel like peers can help people come to those decisions. What do you want? You only have so much time and attention. You only have so much energy. Devote it toward the life you want.
Absolutely. Alicia, can you discuss the importance of building a supportive community for individuals in recovery, and how you facilitate this in your role?
Yeah, so a great example of building a recovery community, if I may, is Thrive down in southern Indiana. I want to give a shout out. Building communities like that, right? That's what we all hope to do. And one of the ways that we've done it in northern Indiana is through events. And now it's being done all over the state. And there are amazing events all over the state. You look at Recovery Rocks in Fort Wayne, it's amazing. If you haven't checked it out, you definitely need to. And now you got Summer of Recovery, right? I'm definitely plugging that one, because that one's my baby. I'm loving that. 5 different cities all over the state that we get to go to and be a part of and build up recovery culture. Mm-hmm. That there are multiple pathways to recovery, and it's okay. It's okay to come out and talk about your way and to build up each other through the process. And so building these communities, and you look at what the recovery cafes are doing, it's creating a culture. Yeah. You said it best, Nicole. You said it's a movement. Yeah. It is a movement that is happening in Indiana, and we're so blessed to have the state support that we have. We have people like Doug out there championing and opening up centers. He's there. He hits the streets. And I think that's what makes us different and sets the tone. That, let's keep going. Because there's room for all of us. And there's not enough beds yet. Because for the people that are still out there, we got to keep paving the way for the next person. And so this movement that's happening in Indiana, I'm so proud to be a part of. I wasn't born a Hoosier, but I'm really proud to be one.
Awesome. Thank you so much. Thank you. All right, so to kind of piggyback off that a little bit, what do you see as the biggest impact since peers have become more widely available in the workforce? We can start with Nicole.
Since peers are more widely used in the workforce, I think peers should be everywhere, right? I think peers should be not just in clinical settings and not just at recovery places, but there should be peers, at low-income jobs where people are incarcerated in factories, so so that we can at least get the message out to people that we're here to support them regardless of where they're at in their recovery. If they're in recovery, if they're not even thinking about it yet, that, this could be an option, this could be a resource for you. Just opening people's eyes that we're available, and that all we want to do is support you with no strings attached, right? Because a lot of times in mental health and substance use, there's strings attached to why you're giving me something or why you're doing something for me. And so you don't ever get to see a relationship that is healthy relationship. And when somebody comes alongside you and just wants you to be healthy, then you learn from that experience. And you just can't, there's just nothing that compares and opens your eyes more than somebody coming to you and it's like, okay, so what do you want to do today? Oh, you need to do this today? Okay, well, I can help you with this, and I can help you with this, and I can take you here. And it's just like this weight and this pressure gets lifted off of you, and you're like, whew, okay, I got hope now, right? I haven't felt that in a long time, because isolation kills people, right? And this is the reality of what happened before this started happening, right? People didn't have anybody. They didn't know any kind of resources. So people just ended up dying. And being in isolation is not a good place to be. And I just love that we can be people's support, we can be their cheerleader, and we can be the bringers of hope at all times.
Yeah, thank you. Thank you. Sarah, how do you feel about that?
I think one of the big changes that I've seen as peers have become more widely available is harm reduction has become more open. Multiple pathways to recovery has become more accepted. I feel like before there were a lot of peers, it was, here's where you come into the system. You may or may not work your way out of it, to be perfectly honest, but this is the only way in. This is how you come in. This is your door. And that was it. And if you couldn't find the door or it wasn't available to you, you maybe didn't get services. And that, I feel like peers have said, well, we have to help them when they're over here because this one door is just not doing it. I would like to see there, more multiple, pathways to recovery with mental health as well, and more harm reduction for mental health as well, in terms of, maybe you tried therapy and it didn't work. Okay, well, you've tried one therapist, you've tried one thing. You should have a toolbox. You shouldn't just try one thing for a behavioral health issue. You need what else have you tried? I've managed to do my recovery. You can do your recovery. If that didn't work, try this. If there's no one door, we got several things you can try. And I really think that that's because peers have used their voice to advocate for people.
Yeah, yeah.
I would say more people are alive. Mm-hmm. Look at the overdose numbers. Overdose Lifeline and the Narcan. Peers are getting Narcan into our communities. Peers are being trained and training other people on how to use Narcan. More people are alive. And I think that says it best.
Absolutely, yeah. No, I agree with all three. Those are excellent answers. We'll get one final question in. So, what can the leadership of an organization do to make peers more effective in their roles? Let me start with you.
Just to be open and honest, and because we're peers, so we need a cheerleader too, right? So our supervisor should be our biggest advocate, our biggest cheerleader, our biggest person to tell us when we're wrong, right? It should be a relationship that we have with them that is open, that is honest, and that is okay with mistakes, right? Because this is a learning experience, right? Nobody's gonna get it right the first time. And you have to make mistakes in this so that you know how to do this. And just for people to be accepting of that part of it, that, you know, we are not going to be perfect in this, but we do have to have open communication, and we need that care and that love too.
Absolutely. Sarah, how do you feel?
I think it's very important to not ask your peer to do like absolutely everything and give more than they are capable of giving, because they see the need. Some of them are going to just want to give everything, and it's not good for your recovery because you need to take care of yourself. So I sometimes see organizations are like, well, they're willing to give it, I'm going to ask it for them. Well, you need to realize that they have an issue. They're going to need to take care of themselves. Just because they're willing to give it doesn't mean that it's ethical of you to ask for it. I do really quick want to say that all these people up here are here because of peers. We saw someone with lived experience that gave us hope, that told us that we were that they made it, we could do it. And so, like, this is all peers. This is what peers did.
Absolutely.
Oh, I love that. I would say from an organizational standpoint, don't say, you can't pour from an empty cup. Don't say, if you need anything, let me know. We're not going to tell you. We don't know how. I didn't know how. I worked until I couldn't work anymore. Physically, emotionally, spiritually, my recovery was drained. I gave everything I had. From an organizational standpoint, take care of your peers. And it's not just a weekend shutting off your phone. That doesn't do it. Are checking in on your peers' recovery. They shouldn't miss meetings to do anything for the organization. Because at the end of the day, they could lose everything. So I would say, from an organizational standpoint, make sure and support and advocate, be a cheerleader for your peers' recovery.
Yes.
Because they need it.
Yes, thank you. So that's been one of the biggest blessings I think that I've received, is getting to work with individuals like you guys every day. I want to thank each and every one of you, or each one of you, panelists, for genuinely sharing your thoughts and your experiences today, and how you feel on these topics. Let's give them another round of applause, please. These remarkable individuals underscore the vital role of lived experience in an organization. Peers complete therapists, social workers, nurses, doctors. Their role is not to replace, but to enhance and provide an added layer of support. It is crucial to ensure that peers work within their scope of practice. When you've met one peer, you've met one peer. Each experience is unique, spanning substance use, mental health, trauma, and beyond. Please join me once again in thanking our peers for their dedication and openness in sharing their journeys.
Well, thank you, Andrew, Sarah, Nicole, and Alicia, for your work. Alicia, do you need help down?
Didn't need a parachute.
So up next, we want you to hear more about this work from the perspective of the employer. You know, what's working? What are the unique considerations, and how can you set your peers and their supervisors up for success? We're excited for you to meet the leaders from Community Health Network and Centerstone. And at the end of the discussion, you'll have a chance to ask them questions. Leading this conversation is Lindsay Potts. Lindsay is the Director of System Transformation at the Division of Mental Health and Addiction. She leads the implementation of the 3-pillar 988 Behavioral Health Crisis Response System, Suicide Prevention, Disaster Behavioral Health, and CCBHC implementation. As the panelists make their way to the stage, I invite you to watch another short video, this one showcasing the faces of many dedicated peers working in our communities.
Well, I'm in recovery from quite a few things.
Substance use disorder, panic disorder,
heroin and meth addiction,
Methamphetamine abuse.
From PTSD, family experiences.
I'm in recovery from heroin, opiates, cocaine, meth,
alcohol,
crack cocaine,
opiate use disorder,
complex PTSD,
trauma based on a family that used substance,
addiction, and mental health.
For me, recovery means the end of suffering.
Growth.
It means life. Willing to do whatever you need to do to make sure that you are healthy.
Gaining my life back.
Acknowledging that we are all human and we all make mistakes, and those mistakes don't define who we are or the life we deserve.
A change of life.
life and death.
Not just existing in life, it's living in life.
For me, being a peer means using the things that I've been through to be there for others who are going through similar situations.
Just to love other people where they're at.
To advance. Sharing my knowledge in my recovery.
Maybe if they had somebody who had more knowledge and experience than I did at the time, they would still be here.
Just being someone's best friend on steroids.
Ending suffering.
To be somebody that people can count on.
Being a peer is everything. And being a peer is something I wish I had.
To simply give back without expecting anything in return.
Show compassion and love for others without limitations.
Giving back.
Just being there for someone.
And I'm grateful to have that chance to be able to help people.
To just give somebody hope and seeing them where they are, not the addiction or the mental illness or whatever they're doing or whatever is going on to them. Just seeing the person for who they are. It's love.
Thank you, Director Hunsinger, for that wonderful introduction of our next panel. Before we get started, though, I do want to take an opportunity to have another round of applause for every peer in the room. I think we've heard a lot of amazing stories today that will set the stage for what this challenge is going to be for leaders. And so I really invite all of our leaders to not be on your phones, to fully be present during this conversation, as this is directly at you. So we heard the challenge from our last panel of how do we lead effectively in our organizations to have a peer workforce that's healthy and thriving. And so as a clinical leader myself, I know many of you in the room, but for those I don't know, I am a licensed clinical social worker, and I have worked with the peer workforce since 2014. At that time, I did not have the tools necessary to, I think, be an appropriate supervisor at that time, and since then have grown and to learn what is necessary for a thriving peer workforce. And a lot of this is empowering those individuals with lived experience to lead the way and for us to get out of the way. And so that's going to be a lot of our conversation today, is learning from some of our leaders here about how they've done just that and continue to challenge us to move forward. So we'll go ahead and get started. So today we have, I'm going to do some introductions of who we have with us. So we have Dr. Allison Bordeaux, who is the Chief Operations Officer for Community Fairbanks Behavioral Health, a part of the Community Health Network, overseeing CMHC service operations and programs for both the Indianapolis and Howard regions. We also have Melissa Davis, who is a licensed clinical social worker and community health worker, serving as a peer program manager for Community's outpatient CMHC clinic on the east side of Indianapolis. We have Suzanne Kozel, who is a licensed clinical social worker and has served as CEO of Centerstone of Indiana since 2009. Centerstone provides a broad continuum of outpatient community-based services and residential services, serving approximately 32,000 individuals annually. And lastly, we have Jennifer Scott, who leads Centerstone Stride Center Mobile Crisis Response Team, serving 5 counties across the southwest central region of the state. Thank you for joining us and helping us learn from you. So I want to begin with a question for each of you. So we'll start with Allison on this one. And then each of you will answer. What does the role of a peer mean to you and to your organization?
So for those that don't know, we've embedded peers into our emergency rooms. And so having them in the emergency room and having just that expanded continuum of care has been excellent, they've really been integral and part of our team. But when I think of the peers, I think of the two most distinctive contributions peers have made really comes back to that hope and empathy. Having someone at the bedside, after an overdose, when you are potentially at the lowest point in your life, there with you, that has lived experience, that is there to share, and knowing that, they're really there to just, again, provide that hope and empathy, because I've been there. I've had that experience, and recovery is possible, and I'm here with you. I'm here to connect with you, to engage with you, and really to help you navigate a system that can actually be fairly complicated. So that's been what has been wonderful, and I feel so honored that we have been able to embed peers in our emergency rooms.
Excellent. Thank you. And Melissa, what about you?
Hi. To build on that a little bit, I think our peer professionals really personify possibility for our patients, which is really alliterative, but it also is kind of how we try to keep in mind with every day that we're doing the work, that we can be the person that is walking alongside someone through the systems that are very complicated, as Allison said, and actually give folks who are in the thralls of their substance use, their trauma, their body and brain, can't get a vision of anything different, a tangible individual who will sit by them, see them as a whole human, and give them a vision of what it can be. And then, again, as everyone has said today, I think that bridge, right, of being able to help somebody actually walk into the spaces where they can be seen and connect.
Sure. And Suzanne, what about you?
I think, peers have been part of our workforce for a really long time, and I think what really is true from my perspective is they're the hope experts. You really just illuminate the power of authenticity and the path, and really kind of create that space to engage and connect. So that someone can really begin or pick up or work through a point in their recovery journey. To me, they are essential part of all of our clinical teams.
What about you, Jennifer?
I am really proud to work with peers, and I am proud to be a peer. I love my job with Mobile Crisis. We get to go out to the streets, and we get to meet people where they are in the moments that they truly need us to be there. I was listening to the peers on the stage talk earlier, and all right, it is a movement. Let's go. You got me ready. I want to keep that momentum going that I heard from the peers on the stage earlier, and I'm joining you and I'm with you. I think that what we are able to celebrate as a Mobile Crisis team right now is that we have a team of peers in recovery that are doing exactly what Suzanne said, which is showing up to folks who are saying, every door's closed, I've tried this, I've tried that, nobody cares, it's not working. And a peer will say, look right here through this little crack. You see the light? We're here for you, and let's keep it going.
Excellent. Well, thank you all for sharing such wonderful insights. The next question is for Suzanne and Allison, and we'll kick it off with Suzanne. But tell us about when you brought peers into your organization. What led your organization to bring in peers, and what roles do they fulfill within your care teams?
It's funny, we were kind of getting together a group of folks who's worked most intensively with peers, and we're trying to think back, what was it that year or that year, and what happened in my life, so we can kind of judge. But I think we figured out that we really started in 2009. We opened our first recovery engagement center, brought people with lived experience in to run that. But that was really just the very beginning of our journey in this space. And of course, when the training was launched in the state, we signed up right away. But again, it was just a real iterative process of expansion and work. We were really fortunate to have a number of grants, both in reentry work, in building recovery-oriented systems of care, and later then also in integrated health work, where peers were like front and center key members of the team. And I think that just having that happening in multiple places in our organization really, I think, let us develop then the systems and the support and the culture in our organization that really invited, valued, supported, held up lived experience. And I think that, so it's been a long journey, but I think really for us began in about 2009.
Mm-hmm. Yeah, so we've had peers for a while, but not explicitly for SUD. So we had, taking a look at the data, about 50% of overdoses were coming to community East emergency room. And we knew that in other states, really best practice in other states, they were doing some of the similar work in healthcare systems where they were embedding peers. And we were like, how can we do this? We need to do this. And so we were very thankful when we were awarded a federal grant in order to embed. And we started doing this in probably about April of 2022. We embedded peers in our East ED, that's where we started. And by February of 2023, we embedded in all other 4 hospital emergency rooms. And at this point, we've served 2,895 individuals at bedside due to coming in for overdose. And so it's really been, so on average, we're seeing about 110. And I'm, again, so I can't thank the team enough. We've engaged, and this is one of our metrics I think we'll talk about here in a minute, but 96% engagement to get individuals into some sort of level of treatment. And so it really has been so impactful. And we, like I said, it's just really become a part of our team, and we really appreciate that continued kind of care, that continuum that we're able to have in big healthcare system for sure.
That's fantastic. And with that, what challenges have you had in integrating peers, and how have you overcome them, both again for Suzanne and then Allison?
You want me to go first?
Yeah,
okay. So, gosh, I think that the one that I'll kind of speak to first was finding a way to fund the role of peer specialists. And we were really fortunate to have a number of federal grants, again, that helped us really start that work, build those programs, and create the space for that. And honestly, just having even as we've done more of it, trying to find the funding so that we can have a living wage for our workforce, that's been the biggest challenge, I would say. The other thing is just really creating the culture in our organization around the role of peer within a treatment team. Because of course, I mean, that was new for us. I mean, people perhaps had lived experience, and some were more open about that. But this was kind of an emerging movement in our field, but also at our organization. So we really had to do a lot of work with training our teams and our workforce, of course, supervisors, and then ultimately building the support systems to not just for supervision, but just for peers themselves and communities within our organization to support the work, because it is unique.
Mm-hmm.
So.
Yeah, and really just piggyback off that, I would say that initially even culture within our emergency departments, as you can imagine, it's chaotic in an emergency room, and they don't really want another body in there as far as like help and so forth, because there's so many people in the emergency room. And so it took a little bit of time to get buy-in from our emergency room physicians and our staff, but inevitably they saw the huge benefit, and I think that they would I don't know, they would scream loudly if we were to exit. They have absolutely seen the significant benefit of having peers embedded in emergency rooms. But I would say that was a challenge at first. And then I agree with Suzanne, it's been the financial. We wanted to do this knowing that there were that many overdoses coming to especially our East emergency room. We were wanting to do this, but it wasn't until we were able to really get a grant. Obviously, being embedded in an emergency room and not being a client of our community mental health center, it's not like we really could bill, and we definitely couldn't bill the MRO, peer rate. So this is really complete expense. And so having a grant is really what's given us that opportunity, but also thinking about sustainability. My hope is CCBHC may be able to help with that in the future, so fingers crossed on that.
Awesome, thank you both. And we've talked a little bit about outcomes and how peers have impacted those. Melissa and then Jennifer, can you share a little bit about how you've seen peers impact patient outcomes?
Yeah, I think more anecdotally, as Allison kind of gave you some of the numbers, we have seen patients that have presented to our emergency department at Community East multiple times. A patient that came in 4 times in a month, like basically once a week, and our peers were asked to meet with him, and they would do so each time. And the last time, he asked for a peer to come and visit him, and then at that and I say last time because he was then able to meet with a peer and talk through what he might want things to look like, what next step he might be interested in, and know that, okay, every time I show up here, there's one of you that's ready, willing, and able to sit here beside me and have not turned me away at any single time, no judgment. And he walked through the doors of our outpatient clinic and started on a path of treatment, and even looking into, moving into a recovery home. And so even if it wasn't that first time, he knew he was safe each time, and then was able to ask for it when he was ready and knew that they would be there. And that is just one of the thousands that our peer professionals have been able to make connection with, people who've been able to tell us that, oh, I'm seen and I'm not judged, and you actually care whether or not I keep coming in and out of this place. And that's the difference that we're seeing, is people are actually feeling like they're valued and worth taking those next steps.
Thank you. Jennifer, what about you?
I often think about what we hear from our clients, especially when our peers are showing up to support them out in the community. We hear things like, I don't know what I would have done without you. We hear things like, I thought nobody cared anymore. We hear things like, I really thought I had tried everything and I didn't know somebody like you was there that could help me in the way that you did. I love listening to our peers share in our weekly staff meetings. We always celebrate our successes. We do shout outs and celebrate successes every week. And this gives our peers an opportunity to share with the group what creative thing or what magical moment they figured out in a person's story. I think the only way for us to really share the impact of peers in this work is for everybody to come to our staff meetings. No, I'm just kidding. That's not going to be allowed. But I think the only way that you can really grasp it is to really hear the impact from the clients that we serve. So probably my best answer.
Yeah, fantastic answer at that. And so this next question kind of piggybacks off of what we've been talking about, which is the innovative approaches and strategies to effectively implement peers to enhance effectiveness. So this is kind of like a collab question. So Suzanne and Jennifer, we'll take this one first, and then Alice and Melissa. What are you doing to innovate?
Gosh, so many things, it feels like. So I think that one of the obviously we have peers in our mobile team and our Stride Center, our crisis work. That's been a big part of it. The other kind of more recent new innovation was around employment and using peers in an employment program we have in partnership with the city of Bloomington to clean and take care of our parks in the city. And it's for many folks, they are experiencing homelessness or maybe haven't decided not to stop using. So it's a real kind of entry point, and by using peers as, trainers and crew supervisors, we really have, created another entry point into recovery, into treatment, into a new life and new possibilities. And it's just it's kind of like thinking about where are the many places where having someone with lived experience who can connect in a unique way, can tell the story, can create that point of contact in the treatment process, can really kind of move things forward. Because if people don't engage in treatment, then their recovery process with a treatment provider stops there. So working with peers as a way to make those connections, in this case through an employment program we had that kind of looked at housing issues, employment issues, but also, recovery issues, really has been, I think, had really remarkable, the movement that has happened in that program. That's just my example. You probably have several.
Good job, Suzanne. I think for supporting peers in the workforce, we've strategized on this, and it's evolved and developed for the crisis teams with mobile crisis and the Stride centers. In the beginning, we recognized exactly what we heard one of the peers say earlier, which was, you have to take care of yourself, peers. Remember that. So we tried to strategize on how we could lead by example for that, of course, but also set specific time and encouragement time aside. So for our crisis team, we do have a self-care and resilience hour every week that is facilitated by an amazing therapist on our team, a crisis therapist on our team. It gives us a moment to pause and really think about self-care, the stressors we're experiencing in crisis work, the conflicts that we feel when we don't feel like we're breaking through or helping people as peers. But more important, it's helping us tune into our resiliency. We did a 16-week resiliency training with our mobile crisis responders, and we all loved it. We were able to take a pause every week and remember things about ourselves as professionals and peer professionals that are helping us cope with all of the stresses of the work, but also our own recoveries.
Excellent. Some great strategies. What about you, Melissa and Allison?
Yeah, I'll just quickly mention and pivot to Melissa here, but to, again, piggyback off, we do offer, for the support, we really do offer quite a bit of training, and we do a mind-body medicine to really kind of support with, again, the resiliency, to kind of help with burnout. And so we offer a lot of trainings and a lot of supervision. I think supervision is absolute key, but I'll kick it to.
Thanks, Allison. I think, I actually, in thinking about this question, was thinking about what Alicia was saying just a few minutes ago about pouring out of an empty cup. Peer professionals, y'all are givers, right? And those of us in leadership have to recognize that it's not about not only not asking, but not letting, not expecting, not allowing somebody to give more than what is probably healthy for them or even healthy for the system itself. Because anytime we allow somebody to do more than what they're capable of sustaining, we set up a team and a program that is not sustainable. And so, bigger picture, we need to be looking at our peer professional teams as persons in recovery, but as a team in recovery. And really make sure that we're not saying, hey, recovery first, but not when you're at work. Your recovery first, except, oh, wait, no, these other people, right? We can't mix those messages because we will burn individuals out. We will put their recoveries in jeopardy. And that doesn't get us anywhere, right? Look at all the amazing people we have sitting here who are able to do this work because they're in places where their recovery is as safe as it is anywhere else. And that's what we have to do in the workplace. And in doing that, we have to have individual rounding and supervision that includes recovery check-in, that includes space to be able to listen and hear without judgment. What I love about every peer professional that I work with is they will tell me exactly like it is, exactly how they are, as authentically to them as they possibly can, and they know that that's exactly what I want to hear. Mm-hmm. And then if I have to filter it to Allison, I will. That's fine.
No filter needed.
But no filter needed, to be perfectly honest with you. Not at all. But we don't create authentic and genuine and safe recovery spaces unless we allow for that for each one of the people that we work with. Mm-hmm. And the other responsibility and innovation we constantly have to be working on is ensuring that professionals in the other spaces, medical, psych, specialty programs throughout the hospital network, truly understand what we do, what we're capable of, and the kind of glue that peer professionals can be in pulling together a siloed healthcare system by really being the person that can connect the person to each part of that. And this is the future, is that our peer professionals really are like the arrowhead to whole person healthcare. If we're doing it right and we're making sure that we take care of our peer professionals as individuals, but as also a holistic team unit.
Wow, those are some fantastic ideas. I hope y'all were taking some notes. I know I was. And so this one's for Allison and then Suzanne, around how do you measure the impact or effectiveness of the peer programs in your organization?
Mm-hmm. So we're continuously, I think, looking at the measures for our impact, and I think we're constantly kind of working on that. I would say that, right now we're definitely, of course, tracking how many individuals we're serving, where they're coming from, what level of care do they need, where do they need to go to care, and so forth. And so keeping quite a bit of data on that. I think even to what Melissa's saying about peer professionals, I think the other piece too that peers really help with, not only are they helping to navigate and keeping those individuals engaged and keeping them along this path, but also even connecting them. I mean, recovery is lifelong, right? A lifelong journey. So then keeping them, even getting them connected to the evolving recovery, the RCOs outside, the non-clinical, the support systems and so forth. And so all of this is to really help support the individual in the recovery process. And I think we're constantly taking a look at how we can even evolve and what we can really be measuring without wanting it to go too clinical, right? Because we want to keep in the scope of what the peers do, but also just looking at those impacts, recidivism, back into our emergency rooms and so forth are the things that we're measuring and taking a look at.
I think that for me, the chief measure that we're using is engagement and the kind of the impact on engagement and continuity and care where we have peers involved. I think, otherwise we have a lot of teams and programs with outcome measures around emergency room utilization and housing and health metrics in terms of those biometric measures and how those are improving or changing over time. And all of those tie back to the work that our peer recovery specialists and community health workers and others are doing as part of that team, as a key part of that team.
Awesome. Great. And so recruitment, and I know this is kind of a pain point, recruitment and retention for the peer workforce. So this question is both for Suzanne and Jennifer, and then Allison and Melissa to take, is how do you know when you've got a good peer, and what are the best practices to share that supports the recruitment and retention of peers?
Okay, I'm gonna jump in because I'll be short. Because I don't do the hiring directly, but like when I was talking to people, like, how do you know? And I think one of the things that I thought was really brilliant was in the interview process, you ask them to tell their story, and that really says a lot about where someone is kind of in their own recovery process and their comfort with connecting in that way. I think that. Recruitment. We had trainers for a long time. I think beginning in 2015, we were training peers. I think we've, trained over 150 peers that have most of whom have gone on to work with us in some capacity. But recruitment and retention is always a challenge, and I don't think that's different with peers than it is with our workforce in general. But I do think that. It's really cool as we kind of look at the kind of opportunities for better supervision, better support that frankly is so applicable to everybody in our workforce in terms of really needing to, attend to, everybody needs to be, attending to their well-being, and you don't leave that at home. You actually do that at work, and creating systems and supports in how we do that has been really critical to retention.
Okay. I'll definitely have Melissa chime in because she's the one that's been doing most of the hiring. But what I would say, something that I've found to really be important as far as retention, and I don't know if it's necessarily necessary, but I think it's really been helpful, is that Melissa herself is a certified peer. And so being able to be an operational manager and have a great understanding of kind of our operations, but yet being a certified peer, she really gets it, right? So she really is able to kind of run interference, as she was saying, being able to kind of say to me, but I mean, she's able to like kind of run interference on like hospital policies and procedures and helping our peers to really understand, but also in reverse, being able to explain to like whether it be myself or to other leaders, like, okay, this is why this individual is doing what they're doing. This is their role. This is, so I mean, really just having that really having that experience and being a peer herself has, I think, really been beneficial in kind of navigating our system and helping with retention.
Oh, thanks. Recruitment and retention, I think if we lean into some of the foundations of recovery, which are connection and authenticity, right? If we look at those two pieces, those are the things that if we utilize those as employers, we're going to be able to not only recruit but also retain. Every peer professional in here knows somebody who knows somebody who knows somebody, right? The network is big and growing, which is beautiful, but it's also still small. And so utilizing our connections at RCOs and other places and with the MHA and MHAI, that's part of the recruitment strategy, right? Is to get referrals. Hey, you know somebody who's great? Awesome, let's go. And then retention is about that connection as well. We have 24/7 coverage in our EEDs most of the time, as best we can, which means that my peer professionals are, that team, sometimes you're all by yourself for a whole shift as far as being the only one on the team present. And so we have to be intentional about making sure we stay connected as a unit. They're connected to the peers in the outpatient clinic as well, so that we're ensuring that nobody's feeling like an island. And that's a huge piece for any of us, right? Because again, isolation is where sickness lives, right? The connection is where we find our healthy life. So keeping that in those spaces helps to ensure that our peers are able to do the work and stay with us. The other part is making sure we're looking at the peer role as a career path. It is not the stepping stone to getting a master's degree and becoming a therapist. It is not, the first step in doing this or that. No, this is the career. This is what you do for the rest of your life, and making sure that we have training and support and pathways for individuals to grow themselves and progress in that career is vital to us sustaining.
Excellent. Yeah, some really great points. So we're at our final question before we open it up for all of you to bring questions to this amazing panel. So in just a few words, knowing that everyone's in a different place on their journey, what advice would you give organizations considering implementing peers, whether they're just starting out or further along? And we'll start with you again, Allison and Melissa.
I think the biggest advice, first off, you should do it. Done. No. I think the biggest advice is to really make sure that you've got the training and support and supervision. There definitely comes with, there's definitely some challenges that can come with any type of professional. And so I think just making sure that you've got a really good training structure and supervision is extremely important. And so that's probably the biggest advice that I would give.
So, anything to add?
Funding. Make sure you're planning as far ahead as you possibly can, because just like we've found in our emergency departments and in our outpatient clinic, there is no replacement for peer professionals. There is no way to make it work differently, and so once we have them there, everybody's going to want them to stay. So, do your best to try and make sure you've got that longevity plan, because that is definitely one of the biggest challenges.
Suzanne and Jennifer.
I say go for it. Everybody go for it. So I would really, I guess, listening to Davis in our table chat that we had, I do think that a part of it is making sure that you have a peer that's leading the peers, if that makes sense. There is sort of this, clinical language that happens, and then there's this peer language that happens, and you gotta find that person that's there in the middle that can kind of help both understand one another, if that makes sense. So you've often heard today the bridge, right? So I think that the best person is to find a peer leader that can fill those shoes and invest in that person as much as you can and support that person as much as you can to lead a peer team.
Yeah, everybody's had really wonderful points. The only thing I'd add is that I think there's investing in training everyone in your organization about the role of peers, and investing in really developing, evolving that peer, kind of the role of peer in a system of care is so important, that it's not an isolated program over here, but it's really an integrated part of the team, just like our nurses and our therapists and our recovery coaches and our nurse practitioners or psychologists, whoever. So really spending some time to understand, helping everybody, not just the peer and the supervisor, but everybody understand the role of peer, and really cultivating that culture over time. And I think leaders have to talk about that and promote that and support it, and really be willing to, kind of wave the flag and declare the importance, because to me that really is what makes it more than a program or a position. It really makes it really an integrated part of our delivery of care. So.
Excellent. Mm-hmm. Thank you all. Let's give them a round of applause for all that. Okay, so now we have some time to take questions from the audience.
Thank you all very much for such a great presentation. And as I look around the room and, oh, that's okay. Okay. Sit on it. Okay. Thanks, Becky. Thanks so much. I guess my question is, I look around the room and I see so many community mental health colleagues. We've all had peers for a very long time, and we've all struggled with the reimbursement and the recruitment and the retention, with losing our peers to the RCOs because they're paying more than what we're able to do. Phil Stuckey, I'm specifically talking to you. Just kidding. Kind of.
Kind of.
I love Phil. I just wonder, other than grant funding, do you know of or have you developed any very innovative ways to make these programs sustainable? And relatedly, is there a way forward for the state that you think would help cover that? Softball question.
CCBHC, maybe? Really, I mean, honestly, I think that's everything you're saying, Beth, is super important. I think that's the challenge, because it does feel at times like we're going kind of grant to grant to grant to grant, and more so in this space than in maybe other elements of work that we do as an organization, and that's not how it should be. I mean, just flat out. So creating, as I was saying earlier, creating a reimbursement rate that allows for a living wage, or incorporating the peer role really explicitly, as I know, the state has done with the mobile teams, or with, the CCBHC model, I think is really, that's, to me, like that's the path forward.
Yeah, I don't know if there's much I can add. I agree.
Other questions?
Thank you for your comments. We've talked, I'm from a CMHC, and we love our peers, and we've done a lot of work inside making them part of us. Maybe I'd invite you to reflect a little bit on what you've had to do externally, because I can think of a painful conversation with a local police chief who didn't have anything good to say about harm reduction, and an uncomfortable conversation with the head of our community corrections workforce center when they called for our mobile response team. They went, the peer went in, greeted the person with, "Hey girl," and later the head of the work center complained to me because, that peer just wasn't professional. And I wanted to say, that's the magic. But what have you had to do with external bodies to sell them on this new idea?
Take note. I'll just really quickly say, it's really helpful to have police chiefs who believe in peers talk to other police chiefs that don't quite get it, right? Or hospital CEOs, or ER docs, or whatever. That peer-to-peer, professionally speaking, is really been, I think, a key for us in opening up people's kind of just their ignorance about what the value and the role and the power and the impact.
I think for us with Mobile Crisis too, we're boots on the ground. We're out there. We're showing up. We do take time to have conversations with different providers as well. It's okay to take time and say, this is who we are. This is my job title. This is what we do. This is what we hope to continue to do. And this is how we're showing up for people. I think that those relationships are built kind of on that ground level up as well. And I think all of our peers on our team, including myself, when we're out and about in the community, we take time for those conversations and we let people ask us questions. And we also listen to their feedback and their ideas. I've listened to the sheriff's department folks. I've listened to police department folks that said, have you ever thought about, or do you think this would work, Jennifer? I'm like, oh, let's try it, So that partnership and that collaboration can happen boots on the ground as much as overarching as well.
Mm-hmm. Absolutely agree. And I think that, continuing to have those conversations, and I think even providing some of the data at times is so important. Yeah. I remember speaking to a chief of police at IMPD that was he was a partner actually in mental health, so kind of opposite of what you're saying. He was actually a big partner, but he couldn't even get his own lieutenants and so forth to understand kind of what was happening with overdose, because they were going out and having to Narcan somebody maybe 2 times that day. And so they were getting very kind of frustrated and feeling pretty defeated. And so I think having the data of we were able to, come and meet them in the ER, have a peer meet with them, get them engaged in treatment, being able to provide some of that, this is the importance. These are the success stories, and this is some of the data that we're able to share with you, and keeping them out of your jail, keeping out of, that kind of thing, to really kind of paint that story for them and get them on a path of recovery. I think it's just continuing to have those conversations and sharing those successes and bringing a peer with you to some of these community stakeholder meetings to really be able to share some of the successes from that point of view. I think is also integral.
I think when they give you a door, you walk through it. So when they say, hey, that person wasn't very professional, I'll go, I'm going to argue with you because they were exactly the kind of professional they need to be. And let me explain, and I'm going to tell you why. It may not be the professional in your view, but your approach to professional approach hasn't gotten us anywhere either, has it? So maybe we give this a try, right? And I can be mildly antagonistic at times, but again, if we're going to be authentic, we're going to do this the right way, right? We have to be genuine, 100%. And even in those moments of being genuine in that conversation, can be just that little bit of a wedge to open that door so we can sit at the table and actually have the conversations of how do we compromise and how do we collaborate. Conversations of harm reduction that I had with criminal justice system in Hancock County years back was a lot of just sitting down and talk, right? And being patient, but also being willing to say, hey, but that's not working, right? Or this is why it's different, and let's explain it and let's figure it out. And then they've come a long way. We've all come a long way.
Other questions? Don't be shy. Got a lot of leaders and passionate people. Okay.
I have a question. I have a bad habit too of when someone gives me a microphone, I lose my entire train of thought. So my question is predominantly for the folks that have peers in the ED specifically that you guys talked about. Do you guys use peers in the ED specifically for post-overdose, or is there an opportunity in a screening portion of a patient intake where you might introduce them to a peer based off of their screening results? And if so, can you talk a little bit about the barriers, challenges, and successes that you've had with that?
Yeah, thank you for the question. So no, our peers will receive a referral from the medical team for any substance-related issues. So it's not exclusive to, hey, this person experienced an overdose and that's why they're here. Our peers will meet with anybody that expresses any sort of concerns or issues with any substance use. And so we have the ability for the medical team to put in a referral into the electronic health record system, and the peer team then collaborates with the nursing team to figure out, okay, when should I meet with them? And I think that's one of the toughest dances for us is, when is the patient actually medically stable enough that it will make sense, that they'll even know that we're in the room, and can really give consent to speak with us, right? We want to make sure that they're actually in agreement with talking to us. And so trying to kind of sort that out, and using our electronic health record system in a way that allows us to communicate with the medical team, and try and juggle, okay, I've got 3 patients that are one to see me. How do I prioritize who's ready when? Is an ongoing kind of skill that the professionals have to use. And then the other part is we're a big health system, and there's lots of different individuals that could be offering some assistance. We've got our behavioral health crisis department that assesses for whether or not a patient needs to be admitted to the psychiatric units. And also we have access to Community Fairbanks Recovery Center, and So how do we make sure we're getting the right person involved at the right time is an ongoing kind of moving Tetris game. But the peer professionals that have been doing it for a while have really gotten a rhythm down and have built relationships with the ED nurses, with our crisis therapists that are operating remotely and things like that. And it's really making sure we set up routes of communication so that all those pieces can try and work together. And it's an ongoing work in progress too. Like there's still lots for us to do there. Did that answer your question? Well, okay.
And I think we are, again, blessed in a lot of ways that we have such a large continuum of care at Community Behavioral Health. And having, like I said, an opportunity for Fairbanks Recovery Center, lodging, residential beds. I mean, we've got the whole continuum, but we still are meeting the individual where they are and their preference as to where they want to go. So we refer everywhere. I mean, we really want to meet the individual where they're at. But to the point, about 42% is actually alcohol. Only about 24% has been opioid. So just to kind of give you some numbers on what we're seeing. So we treat everything. Anybody coming in with substance use.
I think we have time for one more question.
I'm pretty loud. I don't know if you have to jump all the way over Becky. So I'm just thinking about the conversation that I think it was Sarah from Key Consumer was talking about, and I'm just wondering your insights on what you think that community mental health centers need to do more for building the mental health peer workforce. I mean, I'm thinking about we are serving all of the adults with serious and persistent mental illness, right? And so that's the one thing I'm walking away today with is have we done enough in that area? And I just am curious, anything that you might offer on really what we should be looking at, right, as a system for those folks.
Yeah, so I think for us, we've used peers in the context of ACT teams and also our integrated health teams. So those are like two places where the primary, the person might have substance use going on or they might not, but they definitely have mental health diagnoses and issues and things that they're contending with. So that's, so yes, I agree. I'm not sure that we necessarily distinguish as this type of peer or that type of peer. It's, we have the different teams working with different populations, and they all include peers. And I think that's really, again, part of that culture of really embracing and elevating lived experience as a piece of the treatment team.
I think that, we have had several peers apply to work with mobile crisis who their therapists have recommended this to them, to consider it, look at the progress you've made in our treatment together. They've kind of nudged them to consider, try this now, go interview, see what happens. I love those stories. And I really do appreciate your question, and I do, my personal story and the way that I express that I'm a peer is that I have recovery from mental health concerns throughout my life. I think that I try to share that story and try to share that with other people, other professionals as well. It was the peers on my team that showed me how to be vulnerable and speak up about that and recognize that I'm a peer too. It took those peers around me role modeling that for me at the beginning of starting with mobile crisis. So I think those of us who are peers with a background in, mental health recovery is so unpredictable for each person, but just as with substance abuse, we can share that story of hope. We got there. We survived sometimes, we thrived sometimes. Right now I'm in a thriving stage, but you can do it too, and we'll be present and we'll be here for you. One of my favorite moments as a peer recently with mobile crisis is helping someone get through the anxiety of driving to that inpatient facility, right? What does that look like? I know a certain approach that I can try because I've felt that before. right? I know kind of you just take the lead from the person who's experiencing the anxiety. But the moment that I loved the most was walking through the door after we made it. We didn't bolt from the car. We didn't take off or make a different choice. And this was important. I mean, this was a high-risk client, a high-risk suicide client, okay? But I loved walking through the door and just saying, here's my hand if you need to hold it. And that's all I had to do in the lobby. That's it. I didn't have to say anything else.
Yeah.
And there it was.
I think that I think it's a huge benefit, and I think we need to do more of it. I know that we've had peers throughout the years, just as probably you have, that have worked with more of the SMI population, and especially like in our clubhouse, I would say. And I think we just need to, as far as community, we need to do more. I think with more of the mental health peers, and I think what has been the limiting factor is that it really comes back to what Suzanne was talking about, the reimbursement rate, and really not wanting to convolute the role. And I think what has sometimes happened is they become they're doing skills training and development, and it's kind of convoluting the role of the actual just peer, even though they may be a peer, in recovery. But I think that we need to work on that more. And my hope is with like ACT and needing to bring that back with CCBHC and so forth, that maybe the CCBHC rate will help kind of support those even more. But I agree with you.
Well, as we wrap up, I just want to again thank you all for being not only open, honest, vulnerable about what you've done, but also where we still need to go. And I hope each of you have then taken that as a challenge to move forward into your organization. So challenge each of you to take something from what you heard today and implement it. To make the change, to reinforce the movement that's happening that we know is critically important for us to take this next step in mental health that involves a thriving peer workforce. So with that, let's give one last round of applause for our panelists today. All right. And we'll hand it back over to Doug.
Thank you again to Lindsay and our panelists. As we wrap up here, I'm sure many of you saw last week the CDC announced that Indiana saw an 18% reduction in overdose deaths for 2023. No, thank you. That's second highest in reduction in the nation, and there are many of you here in this room that have your efforts have all contributed to that positive trend. And so thank you for all the work that you're doing. The one thing that holds people in recovery is the work of our peers. And as we heard in the last segment, sustainable funding continues to be a challenge to expand our peer workforce, which is why I'm very pleased to announce that by close of business today, the Division of Mental Health and Addiction will be releasing a request for funding to help expand certified peer support specialists supported by funding from the National Opioid Settlement. We didn't just ask you all to be here to learn about peers, we're also going to help fund them now. And again, you'll be able to find the RFF on the DMHA website accessible via the QR code on the screens. You'll also see the timeline for when proposals will be due. And our goal when creating this request for funding was to make it as flexible and as applicable as possible to each of your organizations, understanding the unique challenges that are posed in the various settings in which your peers work. This is a 2-year project that will It'll begin to set the stage not just for the expansion of our peer workforce, but also runs parallel to our efforts that were discussed earlier in further professionalizing our peers and improving long-term sustainable funding through the Medicaid program. I would encourage everyone, as they are looking at the application to think through your current funding streams, future business models, and understand our goal is to supplement, not supplant your current work. As always, I want to reiterate the importance of partnerships and collaborations when thinking about your peer infrastructure, utilizing the existing resources within your communities. I also want to challenge everyone in the room to lean into the peer workforce model to enhance those services and to make the connections with Hoosiers in recovery. Before we close, I again just want to thank all of the peers for joining us today. Thank you for using your lived experience to connect and support other Hoosiers. We know the benefits of helping peers also nurtures your own recovery. So please give these folks one last round of applause. One final note, we are planning the 2025 Indiana Mental Health and Addiction Conference, so mark your calendars now for June 17th and 18th of 2025 at the Indiana Convention Center. Also, please take the centerpieces that are on the table. Thank you for joining us this morning. Thank you for all you do, because only together can we make Indiana a better place for all Hoosiers. Thank you.